Hello and a warm welcome back to Drive Time after that short commercial break. And my name is Idrees with you with Drive Time today. Hope you guys are well and thank you for joining me here live on Facebook, but also online and across Middlesbrough and Teesside on 104.5 FM. As I mentioned earlier on in the program, we do have a guest in the studio, and I'd like to offer a warm welcome to Dr. Joe Chidanyika, if I can pronounce that right. And Joe is very patiently waiting for us on the other side of this line. So, Dr. Joe, a warm welcome to you. And how are you today?
Thank you so much, Idrees, to welcome me on your program. I'm very well. It's been a long time. We've worked together for years, so it's really good to be back in the studio to talk about health.
Dr. Joe, just tell me a little bit about you. Obviously, you work within health and well-being setting, but currently you're based within the Academic Health Science Network. So tell us a little bit more about that and what your role is.
Yes. So I'm with the Academic Health Science Network, and there's 15 of those networks. And in particular, I'm resident with the North Cumbria Academic Health Science Network out of those 15. And my role is the National Cardiovascular Disease Program Manager. So we manage a national program trying to increase uptake of CVD health interventions. In particular, we're focusing on cholesterol to increase the uptake of people who've got high cholesterol who are managed well within primary and secondary care. So that is from a national program perspective, which also runs in the North Cumbria.
You talk about CVD, cardiovascular disease. It's an issue for our area here in Middlesbrough and the Teesside. Obviously, your focus is across the northeast. Looking specifically in the Middlesbrough area for the moment. And especially Middlesbrough being a deprived area, it has multiple health issues, and diabetes is one of the things that we, as a community, and predominantly those from South Asian communities, are dealing with as well. So, what sort of things are you doing to address some of these health inequalities?
So yes, so cardiovascular disease, or CVD as it is shortened, is a general term that really refers to conditions that affect the heart or blood vessels, and some of the conditions we know about is coronary heart disease, having angina, heart attacks, or hypertension, stroke, and even vascular dementia. So those are the range of problems that we do find in cardiovascular disease. And a perfect example, everyone knows this: hypertension, high blood pressure. It's a big problem in most communities. High cholesterol equally is an issue. But coming back to your question there, to say what is it that we do and the target communities, we know that 1 in 4 people do develop heart disease, but heart disease is the biggest killer in the UK. And in Middlesbrough, we know over 12 months period each year, we get about 3,200 people who die from cardiovascular disease. But this now is steeped in health inequalities. So if you're from a poor or lower super output area, you're most likely to be disadvantaged, to have health inequalities and die more prematurely. And then it goes without saying that if you are from some of the deprived ethnic groups, which are like the Black and ethnic minority ethnic groups, you're most likely to have a higher probability of having cardiovascular health disease. But this is then coupled by not going to the GP or not being found by the GPs themselves to go under treatment. So our program is trying really to look at how do we look at those population groups who are most at risk of cardiovascular health disease. And then
so you leading on this INHIP program as part of the work of the science networks. Just tell us a little bit about INHIP and what it is.
Yeah, so the INHIP is a national program funded by NHS England and facilitated by the Academic Health Science Network to get a number of projects nationwide to reduce health inequalities. And INHIP really stands for Innovations in Healthcare Inequalities program. So we're trying to reduce health inequalities within our settings through these targeted programs. And there's a range of projects nationally, which are most of them are looking at cardiovascular health disease. Ours in the Northeast North Cumbria, and in particular for Middlesbrough, it's looking at 3 particular groups. So South Asian community, Black Afro-Caribbean community, but also the indigenous white population who are coming from a deprived background, to see that if they're invited by the GP, how can they make sure that they end up being treated? Or if they're not invited, how can they proactively go to the GP and ask for that service? Because there's 2 ways where people get the service. Either they're invited because they're at high risk, or they develop the the cardiovascular risk factors like high blood pressure, then go to the GPs. So we know that those communities are not going to the GP at the rate of the general population. So the program really is to increase and drive that population back to the GPs, or indeed any healthcare professional. It doesn't have to be a GP. It could be in secondary or primary care, or through community centers where they can get tested and then go into treatment.
So, how, in terms of this particular program, how are you going to approach it? Is it like you're going to do some research, identify the issues, and then work with the communities to address them, or just explain what the initiative is all about, and how you're looking to progress it with the support of communities?
Yeah, so with support of the communities, what we're trying to do is really a bottom-up approach. We've done top to bottom, as you know, in health yourself, that we commission a service. We expect a medical model to target the communities that we need. But we know that outreach is not or uptake within the outreach services is not as much. So what we're doing, it is exactly like you say, it's based on behavioral insights, which is part of a research project where we are asking the communities that are affected by this condition, in this particular, those 3 communities I highlighted before, to sit with them, have depth interviews, focus groups, to ask them, do they know about the condition? How do they access the health service? And if they access the services and they find it difficult, what are the barriers that stops them from accessing? But we don't stop there, because it's easy to get barriers. We are then asking them, if this is the program and how it runs, how best can it be better for you to increase your uptake and the risk of heart disease within your communities? Because we know that action really is usually useful when it is actually suggested by the target groups. So our research is trying to understand through behavioral insights, what would communities want to improve that uptake? Then, not just stopping at the research and the recommendations, we will then sit with the commissioners or provider of this service to say, this is what the communities say. What are you going to do about it? And what is the solution? So it's more of a core designing of an intervention rather than the medical model of, this is the money, go out and find the patients.
So, what sort of people would you like? You mentioned obviously people from certain deprived communities and people that reside, and especially those from ethnic minority communities who are at a higher risk as well. So, obviously, looking across Middlesbrough and the Teesside area, so your program is limited to Middlesbrough, I believe?
Yes, it is. Yes, it is limited to Middlesbrough.
So if people are interested in taking part in the research, what's involved? Is it like a questionnaire? Is it a group focus group? Or how do you propose on getting that feedback from the communities?
Yeah, so what we're thinking of doing is having at least a minimum of 18 participants, of which we know we've got so many people who will be willing to come over. But to get the real information, we need at least 18 to 30 people involved in this research. But it needs to be very diverse, as you've mentioned. So we're looking to recruit participants through Live Today, this drive time program. If people are interested from any of those communities, South Asian, Black Africans, indigenous white population, which are based within deprived areas, all they need to do is link up with yourselves. I'll provide my email details at the end of the program, but then talk to the community leaders from those groups, suggest a venue which is suitable and a time that is suitable in their communities. We will come out there, sit with them for an hour and a half, go through this discussion in terms of how they can increase uptake. Then we transcribe all the information they've given to make recommendations. So this is not us deciding what has to happen. We are learning from them. But in particular, I'm looking at South Asian population, not just the male. It could be, for example, taxi drivers, not just the male, it could be the females within this population group. But we've also targeting those black Africans. And it doesn't matter the background. It could be refugees, asylum seekers, or indigenous black and Asian population groups that have been for years here in Middlesbrough. I know we are working with other organizations that are women focused, like Noah Fitness, trying to recruit women, because what we want is a real good, diverse gender mix, male and female, but also not just the BME groups, but also the white population who are also finding it hard to get access to this program. So those are the cohorts we're looking for.
And in just looking at time frames, obviously, once you've had this discussion, it's to look at that information and feed it back to the commissioners and those that are delivering those interventions. So, Joe, we will share your information and contact details to individuals that might be interested in taking part. And we're looking to organise the sessions over the next few weeks.
Yes, thank you. And just to go back to your time scale there. So we're willing to schedule some interviews from next week going forward. So the program plan is from next week until maybe the end of June, to do as many interviews as we can, and through contacts of yourself and any other community leaders who are interested to take part. So that month and a half is data collection, when we sit and understand what is happening. Then soon after that, or in between when we're doing interviews, we then start to get the themes that we need to talk about and recommend. Then we're looking at July and August, having this report written, and then feedback to the communities is very important. So we're not just going to end up with a research paper. We want to make sure that we go back to the communities that contributed and say, this is what you say, this is what you want, how you want the services to run to reduce heart attacks or CVD. Then we also sit down with the providers and GPs to then say, this is the problem, scale of the problem, and how would you then make interventions. So hopefully, we're saying by October, we should have a good feedback loop in terms of everything that has been collected and everything fed back to the communities, and programs starting to run.
Yeah, as you mentioned, it's important to provide that feedback. So many times, you get organizations, individuals, and projects come in and consulting the community, and there's not that feedback loop. And I think it's important that as community members, when we are taking part in any sort of a consultation or research, that we have the opportunity to see what impact that has made. And I think that is an important element of this particular INHIP program. So, Joe, I want to wish you all the best of luck with that. It's difficult trying to engage diverse communities, and especially when it involves health and well-being issues. So, you'll be doing lots of talking, lots of listening over the next 4 to 6 weeks, and see what sort of feedback we can get from our diverse communities here in Middlesbrough. And hopefully you can put that into a plan to speak to the commissioners and those that are delivering. Because at the moment, they are doing their best. But I think if we can get feedback from those that they're trying to engage and see what's the best way of delivering, whether it's, it's in the GP surgery, whether it's in the community centre. So those are the conversations that needs to be had, and that information needs to be coordinated and fed back. So, Joe, so I will share your contact details, and hopefully we can drum up some interest, and hopefully we can get our community members to support this particular initiative.
Absolutely. Thank you for having us. And we cannot wait to see people who come through your contacts, and please get in touch. This is about changing people's life, because every 3 minutes someone dies from a heart attack. And if you multiply that within the course of a day, those are really thousands of people who unnecessarily end up dying. So we're here to make the change. Thank you.
So wise words from Dr. Joe there. We're here to make a change. So please do get in touch with myself or Joe if you yourself or an organisation like to get involved and support this particular initiative. So we're going to go to a song now. So I'm going to say goodbye to Joe and thank him for his time. We'll be back again, maybe in another programme, just to give you some feedback as well once we've done the consultation sessions. But for now, it's a goodbye to Joe. We'll be going to another track now. So let's take a listen to this.